So this is chapter 46 in your book, and it's the child with the cardiovascular alteration. With cardiovascular, we can have a congenital defect, which is one that the child is born with. This usually happens sometime in fetal development, but congenital defects may also happen at birth because of the closure of a lot of those like the ductus arteriosus that must close in that first few breaths of life, and if those don't close, those are still considered congenital defects. You also have acquired heart diseases, so a lot of these are related to another disease process such as Kawasaki's and rheumatic fever, and we'll talk about all of those. Now, to start out with, it's very vitally important that you understand normal anatomy of the heart. So you've already had anatomy and physiology, so please make sure you review this. But just to go over it, you have two atriums and two ventricles. Blood enters through the right atria into the right ventricle. It's then sent through the pulmonary artery to the lungs to become oxygenated. It's then sent back to the heart from the lungs, and it goes into the left atria and into the left ventricle. Now this then pumps it back through the aorta and into the rest of the body. So there's some important parts you need to remember about the function and the structure of the heart. Now, to begin with, the right side of the heart has a lower pressure than the left side of the heart, and this is because the right side doesn't have to pump the blood as far as the left side does. So a lot more pressure is going to be on that left side of the heart. The right side of the heart contains all of your deoxygenated blood, while the left contains that oxygen-rich blood. Now, this makes a difference when we have things like septal defects and your blood is combining, and we'll talk about like left to right shunting, right to left shunting. The walls of the left side of the heart are much thicker than those of the right. What we'll see is that the left side again has to pump all the way through the entire body, and so those muscles have to be much more dense. You do have problems such as hypoplastic left heart where the muscles are not strong enough. You also have, when we talk about increased right ventricle hypertrophy, this is because these muscles have become much more condensed. Now, and that's the normal anatomy of the heart. That's the adult, a child that's out of the womb. Now, we have what we call kind of like this transitional period because we have fetal circulation. There's some major changes that happen during fetal in this transitional period. And that transitional period is going to be that very first breath of life. So we think of that first breath and we think, oh, it's so important for their lung development. And it is, but it's also important because it will actually close some of these fetal shunts. So your ductus arteriosus, your foramen ovale, all of these are open during fetal circulation because it helps bypass the lungs because you're not using your lungs when you're in utero, but you will need them outside of the womb. So that very first breath actually causes them to close, and then the pulmonary system and this resistance is going to start increasing, and all of this is going to start happening because it's going to create that pressure change. So we talked about how the pressure in the left side is greater than it is in the right side. During fetal circulation, they are even, so these shunts have to close in order for that change to happen. So this is your a general review of comparing a fetus from a neonate. So again, the fetus has that ductus arteriosus open, that foramen ovale. All of these are going to help bypass the lungs. You also have the ductus venosus, which is going to almost help bypass the liver and go into the umbilical vein and the umbilical arteries. Now you will see this with more on your newborn and your OB assessments. You have two umbilical arteries and one umbilical vein, and all of this ties into that transitional period, because as soon as that umbilical cord is cut, the blood and the pressure starts to build back up in the body, helps to close those shunts. We get that first big breath of air, and that first cry, and then all of these shunts are going to ideally constrict and then close. This is why you may see sometimes we have infants who have a murmur, and we're not really concerned about it because there are cases where these don't close instantaneously, but they will close, especially your smaller, what we call a patent ductus arteriosus. Okay, before we go much further in the chapter, let's stop and talk about heart failure. So heart failure occurs when the heart itself is unable to circulate enough blood to meet the demands of the body. There's usually a defect in the heart that causes this demand, and it's not the body causing the demand. Initially, you may see that the heart's going to respond to this increase in demand by increasing the heart rate. Well, the heart can only do that for so long, and over time, the muscles are actually going to become hypertrophied. Now, with this hypertrophy, the muscles are not stronger, they're actually weaker. So despite being super large, they're still going to be weak, and they're not going to be able to effectively pump blood. The blood then starts to back up, and we'll see this as pulmonary congestion. Oftentimes in infants and in children's, our heart failure that we'll see is related to a congenital defect or an acquired heart condition, versus in adults where we see it as related to dietary and lifestyle changes. The manifestations of heart failure can vary widely, and they do depend on the severity of the heart failure, the defect, and the compensation that's occurring. They can also be very subtle, especially in infants. So you may see mild tachycardia while at rest, poor feeding, poor weight gain, dyspnea, tachycardia, tachypnea, fatigue, chronic abdominal pain. Older children may actually have a decrease in appetite because of that poor circulation to those abdominal organs. There may be a galloping rhythm when you're listening to their heart. Their spleen can be enlarged. Of course, the heart muscle itself will be enlarged. The liver can be enlarged from everything backing up into the rest of the body. You may have a decreased urine output when those kidneys are not being perfused appropriately. Mottling, cyanosis, and a general pallor are also some of the manifestations that you may see. Now, our diagnostics for heart failure are done pretty thoroughly. We're going to include a very thorough H&P, so we're looking for any signs and symptoms of anything that's prevented before. Did we miss a heart condition, especially if they're a new patient? We may do a chest x-ray. Now, on this chest x-ray, we'll see cardiomegaly, and we may also see some lung infiltrates as that pulmonary edema continues. EKG, if it has started to interfere with the cardiac conductivity of the heart, then we may see some changes there. And then an echocardiogram, which is an ultrasound of the heart, we'll be able to see physical changes within the ventricles and the atrials, and we'll also see valvular changes as well. We can measure like our ejection fraction, which is the ability for the body to pump the blood. Lab work that may be drawn, we may draw an ABG, which is arterial blood gas, and this is just to see if how severe the oxygenation or deoxygenation is. A CBC, they will present with some form of anemia. White count may not be elevated unless it is an infectious process. CMP, we want to double check our electrolyte levels because they can actually cause EKG changes that could lead to heart failure as well. Our ESR, which is our end sedimentation rate, so we're wanting to look and see if there's an inflammatory process, and a UA because we're checking that kidney function and seeing how well if we're holding on to fluid. Now, treatment for heart failure is actually pretty supportive. We do aim to reduce the workload of the heart, but again, these treatments don't reverse the symptoms, don't reverse the causes. So medications like digoxin, diuretics, and ACE inhibitors are all used in pediatrics to help reduce that cardiac workload. Now, ACE inhibitors are starting to be preferred over digoxin. Supplemental O2 can also be given, and our nutritional demands should also be considered. These patients are going to have a higher nutritional demand, but they're also going to have poor feeding and poor weight gain, so we need to take that into consideration when we're teaching these parents. Things that we can teach the parents to do for the weight gain of the child and facilitate that is we can have them time the feedings, because with other activities, these children are going to get very tired very easily. So we want to be able to support them. They may need smaller, more frequent feedings. We want to make sure we hold them in the upright position because it'll help them reduce that their stomach compression and help them with that respiratory effort. Ideally, they should be able to consume an appropriate amount of feeding with every 3 hours or so. If they're not able to do this, we may need to increase and change their formula to one that's a higher calorie formula, like a 20 or 30 kilocal formula. If not, we will need to put an NG tube in and feed them that way. We want to also teach the parents to be on the watch out for signs and symptoms of worsening feeding, such as increased akipnea, diaphoresis while feeding, vomiting after feeding, that's known as like a feed intolerance. If they see any of that or any work of breathing cyanosis, they need to call the provider that they're seeing. Now, digoxin is another medication I want to speak about because it's used to reduce the workload of the heart because it helps strengthen the myocardial contractility, and it decreases the heart rate and decreases the conductivity of the heart as well. Now, digoxin is a big red flag. We need to take special care when we're giving this digoxin. So we want to do a baseline EKG before we start that first dose of dig, and then we're going to do subsequent EKGs just to check and see, because it does interfere with the conduction of the heart. It does slow the heart rate. So every time before we give it, we need to check their heart rate. Ideally, a pediatric's heart rate is going to be over 100 typically. And that's when we should give it. If it's below 100, we need to pause and call the doctor and allow the doctor to be told. You also want to check their kidney function because the kidneys and digoxin work really closely together, and so kidney impairment could cause us to need a smaller dose of digoxin. Also, hypokalemia is related to digoxin toxicity. Now, digoxin toxicity may appear as very vague symptoms such as palpitations or vomiting, so we need to have the parents be on the lookout for those. Other things you'll want to teach a parent when they're giving digoxin is if they forget to give a dose or they skip a dose, then you want to give it as soon as they remember it, and then they can resume the normal schedule. If the child vomits after they give a dose of digoxin, don't re-give that dose. We wait and give the second dose whenever it's needed. If they miss 2 doses or vomit for 2 doses in a row, then they need to be told to call their provider immediately and have them evaluated. Again, vomiting can be a sign of digoxin toxicity. Diuretics, when we give diuretics to any patient, we have to be careful with our kidneys and our potassium levels specifically, because it is very closely related to our heart muscles. So usually we want to give something like furosemide. It's a very potent loop diuretic. It's preferred over the other diuretics. But this is because that they will waste potassium as well. They're very strong, so they're potassium wasting. And this puts them at risk for hypokalemia. Well, we'll also may add on a potassium sparing diuretic, and this is to help with something like spironolactone. It's a weaker diuretic, so it won't have as much effect as a furosemide, but it will keep the potassium in it. Potassium supplements can also be given in tandem with diuretics to help address the hypokalemia. Now, due to the severity of congenital heart disease and its impact on the child's lifespan, the AAP has recommended several strategies to help identify CHD very early. So pulse oximetry is done on newborn babies, usually at that 24-hour mark. It's very quick, easy, non-invasive to do. It doesn't cause any harm to the patient. They want to be at least 24 hours old, but you don't want to do it they need to be before they're discharged from the hospital. We measure these in all 4 extremities. We should not see any variations within the pulse ox of the extremities. Originally, congenital heart disease was based on if they were cyanotic or acyanotic lesions. Now we base them on the flow of the blood. Shunting is something we'll talk about. It occurs when there's an opening in the cardiac chambers or even in the greater arteries. The pressure on the left side of the heart is greater, and so if there's a hole available, the pressure is actually going to force that oxygenated blood into the right side of the heart. Now the right side of the heart feeds the lungs, and so when we have backup into the right side, we're getting extra blood to the lungs, which can cause us to have pulmonary edema. So starting with some of our left to right shunting lesions, so we'll start with the PDA or patent ductus arteriosus. This is an incomplete closure of the ductus arteriosus. Ideally, we want this to close within 24 hours after birth. Ductus arteriosus is one of our shunts that's in our fetal circulation. That shunt closes because there's a drastic decrease in prostaglandin levels directly after birth. If it doesn't shut, then we have a left to right shunting, and there's increased pulmonary blood flow. Our manifestations are all going to be based on the size, so a smaller PDA can actually go undiagnosed or even be left alone to close on its own. A machine-like murmur may be heard. Bounding pulses, even a widening pulse pressure can be seen when we monitor their blood pressure. Treatment, again, is based on the PDA size, the gestational age of the infants, and the presence of any other heart failure. So again, small PDAs can be left alone. Largers can be occluded by a non-surgical, such as a cardiac cath, or a surgical ligation of the PDA. In preterm infants, we can give a medicine called indomethacin, and it is a prostaglandin inhibitor. However, this medication is not effective for full-term infants. Atrial septal defect, is an abnormal opening between the atriums. There are 3 subcategories based on where it's located within the atrium. Small ASDs can be asymptomatic, but other symptoms will include fatigue, dyspnea on exertion, recurrent upper respiratory infections, systolic murmurs, maybe have some mitral valve regurgitation, heart failure, and there's an increased risk for stroke in these patients. Treatment is very conservative, but because they may close spontaneously, typically by about 4 years old. Other treatments include placing like an occluding device or a patch at these places, and then they'll be on a low-dose aspirin regimen for about 6 months post-procedure. We may also use things like digoxin or diuretics to help treat the heart failure. A ventricular septal defect, which is a VSD, is one of the most common types of defects that you'll see, and it's an opening between the ventricles. The child may be, say, asymptomatic, but the symptoms will include a very loud murmur, a palpable thrill, so almost like a vibration around that apex of the heart, that galloping rhythm, and heart failure. In about 60% of the cases, they'll close on their own. Diuretics, digoxin, and ACE inhibitors we give to decrease the afterload of the heart. We may have to surgically correct these by, again, placing some kind of a device that's going to occlude it by a heart cath, or may even have to have surgery to suture the opening or even place a patch on them. An atrioventricular septal defect is also known as an endocardial cushion defect. These are often associated with Down syndrome. There is an abnormal tissue development, and this results in the atrial and ventricle septal defects, along with mitral and tricuspid valve abnormalities. We can either have partial or complete of these atrioventricular defects. Some symptoms you'll see, they'll have varying degrees of heart failure, they may have a murmur present, and they may have intermittent cyanosis. Treatment is they have to have surgical fixation of the defects via an open heart surgery, and will then treat the heart failure. So moving on to some obstructive lesions. In obstructive lesions, the heart actually works harder to try and get blood to force past the obstruction, which is going to result in some kind of heart failure if it continues on. So starting with pulmonary stenosis, this is a narrowing of the pulmonary artery either above, below, or at the level of the pulmonary valve. Symptoms are going to include some exercise intolerances, a right-sided heart failure, murmurs, cardiomegaly on an X-ray, and in severe cases they may have some cyanosis. This can be, our treatments can either be like an observation, maybe even some prophylactic antibiotics if they're asymptomatic, because they are at increased risk for infective endocarditis. Prostaglandin E transfusions can be given. This helps keep the ductus arteriosus open. He helps keep the blood mixing and helps with continue to perfuse the rest of the body. A balloon valvuloplasty can be used to help with dilation of the valve, but if this is unsuccessful, then we'll have to go and do a surgically do a valvulotomy. Aortic stenosis, this is a narrowing of the entrance in the aorta. In mild to moderate stenosis, the child can be asymptomatic or even have something simple like or slight like exercise intolerances, cardiomegaly, murmurs or clicks in their heart, and they are at risk for sudden cardiac death. More severe cases will present with signs and symptoms of heart failure almost immediately. Moderate cases will have regular follow-ups, especially if they're an athlete. We're actually going to recommend that they don't get involved in competitive sports. In more severe cases, we will have to maybe have something like a valvuloplasty to decrease the stenosis. If it continues on, a valve replacement will be needed. Coarctation of the aorta is the aorta is constricted at the ductus arteriosus site. Because of the restriction, blood supply to the abdominal organs can be decreased, kind of resulting in almost like a right-sided heart failure. Asymptomatic children can show blood and pulse pressure differences in blood pressure and pulse differences, in the upper and lower extremities. So this is why it's going to be important to take a blood pressure on both the upper extremities and the lowers to compare the differences. The left-sided heart failure is going to be present as well. If a PDA is open, the child may have right to left shunting as well. Treatment includes heart failure treatments, so digoxin, diuretics, ACE inhibitors. We may do those prostaglandin infusions to keep the PDA open because it's going to help with our lower extremity perfusions. Surgical correction is typically done pretty soon after the diagnosis of the coarctation. So moving on into some more types of congenital heart disease, we're going to talk about cyanotic lesions, and these have decreased pulmonary blood flow. So we'll talk about tetralogy of Fallot. Now, tetralogy of Fallot is a kind of complicated heart defect, and there are 4 very specific pieces. And what happens is there is malalignment of the ventricles during fetal development, and that causes these 4 pieces of tetralogy. The first piece is a ventricular septal defect. The second piece is a right ventricular hypertrophy. The third is a right ventricular obstruction of the outflow. And this is something like pulmonary stenosis. And number 4 is the overriding of the aorta. So the aorta is slightly into that right ventricle where it should not be. All of these will cause and can be identified by what's called a hypercyanotic episode. We know this as a TET spell. Now, TET spells are basically the child is getting very frustrated. They are crying and they turn this blue color. So their face is going to turn blue. They're going to look very blue. They're going to be extremely tired after this. What we'll do is we'll put them in the knee to chest position. Older children may even squat to help them out. So we'll put them in the knee to chest. We may give them some supplemental oxygen, and they may even get a dose of morphine to help suppress that tachypnea that they'll be having. Other symptoms of tetralogy you'll see are hypoxia, some very harsh sounding murmurs, cyanosis with that in severe cases, and then if we do an x-ray, the heart's actually going to look like the shape of a boot. If the lesions are more mild, the child may have what's known as a pink tet, meaning that the hypoxia is mild but is present, but it's not causing cyanosis. Symptoms will start to get worse in tetralogy as that PDA closes. So we're actually going to take these patients into surgery pretty quickly. So they have to surgically correct these defects. This is an open heart procedure, and they will require cardiopulmonary bypass, meaning we'll put 2 almost like stents in either side of the heart. One is going to take it away the blood that's from the body, oxygenate it and give it back to this other stent, so the heart is going to be, nothing's going to be going to the heart. When we're waking patients up from cardiopulmonary BiPAP, they are at increased risk for blood clots, specifically strokes, because of this. Other treatments for tetralogy, we're going to give them an infusion of prostaglandin, just because we want to keep that PDA open at this point. We're going to manage the TET spells, teach parents how to manage the TET spells. We're also going to treat them for iron deficiency anemia because they may be slightly anemic. Moving on to cyanotic lesions with increased pulmonary blood flow. So tetralogy had decreased pulmonary flow. This has an increased pulmonary flow. So transposition of the great arteries. This is an abnormal separation and rotation of the truncal arteries. So the aorta and the pulmonary artery are switched. The aorta is taking blood from the right and the pulmonary is taking blood from the left. It shouldn't be the opposite way. And this is going to cause an issue because now we've got blood in the right artery and the aorta from the right ventricle, which is unoxygenated, and so we've got unoxygenated blood going to the rest of the body, and then you've got oxygenated blood going back to the lungs, and the lungs are not prepared for that. The child may also have a VSD along with the transposition. At birth, the child will be cyanotic, so these are not going to be usually missed. At birth, they'll be cyanotic. They may have hypoxia despite being given oxygen. They'll have almost instantly go into heart failure, and they'll have this progressive desaturation despite our treatments. We'll give emergent infusions of prostaglandin to help maintain that PDA open as much as we can, to help with those lower extremities perfusions. Patients will have open heart surgery and will switch the arteries. Now, the survival for these infants are going to depend very much so on how well the blood mixes while we're awaiting surgery. So if we have larger defects and the blood's mixing relatively well, then the patient may have a better prognosis. Another thing I want to talk about is hypoplastic left heart. These patients are going to specifically present almost in a grayish blue color because they are going to constantly be cyanotic. So it's important to ask, anytime you have a patient who has a known congenital heart defect, ask the family members, hey, what type of, where does the doctor want their oxygen level? Doesn't matter what's going on. See how they want their oxygen levels. Sometimes you may be surprised that the doctors actually want their oxygen levels to be less than normal, and so their normal is usually our cause for concern. I've seen patients who they're like, oh, just keep it above 75. We want to make sure we educate our parents with anything related to the heart, especially those with the congenital defects. We want to teach them the signs and symptoms of heart failure, let them know that these are complications that they need to see, let them know that if they have an increase in cyanosis, they need to call the doctor, or what to do in cases of TET spells. Because of the tachycardia and tachypnea that these patients will have, they are at risk for dehydration. So we want to maintain a good, solid hydration status. They're at risk for more frequent upper respiratory infections because of that increased blood flow to the lungs, and they're also at increased risk for heart infections such as infective endocarditis. Dysrhythmias can occur if the conductivity levels have been altered, such as the SA node if they've been damaged. And we also want to monitor their nutritional intake. We notice this a lot in our younger children and our infants, either weight gain, if they've appropriately gained weight. If they haven't, or if they're having a hard time eating, we may need to consider an NG tube at this point. So now we'll move on to infective endocarditis, or IE. Now this is an inflammation of the endocardial tissues, and it's from some kind of pathogen. It may be a fungal, it may be viral, or it can be bacterial. Most often though we see this as bacterial, Fungal would be more related to like a valvular disorder. So we'll just talk about bacterial in this case. So children who have congenital heart disease, have had a previous cardiac surgery, or have a previous IE diagnosis in the past, they are at an increased risk of having another episode of IE or having an initial episode. We do commonly associate this with a lot of dental work, and this is not your normal like dental cleanings. These are anything that really manipulates the gums, so extractions, root canals, abscesses, anything of that kind that's going to really manipulate that gum and jaw and tissue is going to cause increased risk for endocarditis. And this is because it's going to the theory is it releases bacteria into the bloodstream, since the mouth is such a vascular space, and those bacteria are going to, are going to cling to the first thing that they can find, which is going to be the cardiac tissue because of the proximity. The manifestations of IE are extremely vague, so fever, fatigue, anorexia, malaise, maybe some chest pain, heart failure if it's severe, petechial rashes. There is a risk for having an embolus, so they will have signs and symptoms of that embolus wherever it occurred at. But your hallmark gold standard sign is going to be a new onset murmur or a worsening of an already existing murmur. Now, the bacteria that have implanted into the heart tissue will create what's called a biofilm, and this biofilm is basically comes and forms like a protective armor against our antibiotics, and it makes it super difficult to treat. The biofilm may also have like little spurts off of it, and we call these vegetation, because this vegetation will clump up and be parts of the bacteria, fibrin, platelets that all attach to this and create these little like clogs basically. Now this is where our risk of embolus comes, because if they break off, they do form an embolus. Blood cultures are performed, and we try and find the exact pathogen to give a more narrow spectrum antibiotic if we can. We're also going to be doing blood cultures pretty frequently throughout to try and, evaluate our treatment regimen. Echocardiograms are done because they'll show the presence of a vegetation. However, lack of vegetation is not ruling out of IE. Other labs that we do are CBC, a CMP, we may do an ESR. EKGs may show changes if it has interfered with the electrical activity. We'll also do a rheumatoid factor, and this is done to help rule out some other diseases. Prevention is our key point of treatment here. If they have any of these pre-existing heart problems, then we want to teach them really good oral hygiene to reduce the chance of them having emergent problems where they'll have to seek emergent care. Those at the highest risk are, of course, those with CHD or have like a valve replacement or anything like that. Treatment for IE is a very high-powered antibiotic for about 6 to 8 weeks. Now, these patients are going to be sent home with a PICC line, so you do need to include that in your teaching about maintaining the line's effectiveness. You may have to do referrals for home health care or an outpatient infusion center to get them their antibiotics prescribed that way and delivered that way. There is a risk of contracting IE again once they've had it one time, so prophylactic antibiotics are typically needed before procedures, and this is typically done about an hour or so before the procedure, and this is going to include dental work that manipulates the gums, something like a tonsillectomy or an adenoidectomy, or even a biopsy of respiratory tract tissues. Those are at the highest risk. We only consider those now for those who are highest risk. They are for those who have an unrepaired cyanotic lesion, those who have a prosthetic valve, or within 6 months of a cardiac repair, if they've had IE before, or if they're a transplant patient. Now, these are all of our highest risks that are going to be given the antibiotics before these procedures. Because our dose of antibiotics for these patients is so high, we want to make sure we're doing peak and trough levels and monitoring them closely. We're notifying the providers if the trough is above level, if any of these are above normal or below normal, because we want them to be within that sweet spot. So we'll notify the provider. We're also monitoring for those side effects. So we're watching our liver enzymes to see if we have liver involvement. We're looking at our kidney function to see if our kidneys have been damaged. We're doing frequent checks on hearing and checking for tinnitus to see if they have that ringing in their ears. And that's because some of these can cause ototoxicity. Next, we'll talk about rheumatic fever. Now, rheumatic fever is an autoimmune response. It does closely affect the valves of the heart. So it is almost always caused by a group A beta hemolytic strep infection or strep throat. And this is what happens if they are untreated or even partially treated. This is why you need to stress to your patients anytime they're diagnosed with strep throat to please take the medication all the way through the very end of the course of the antibiotic. And if they have a sore throat, please go ahead and or any symptoms of strep, swab them for strep to make sure you rule it out, because it can cause cardiac problems afterwards. And this is going to typically happen within about 2 or 3 weeks after the initial infection of strep. The body creates these immune complexes that then become lodged in the tissues. In this case, it's usually the heart and joints, and they'll create like an autoimmune process where the body will then attack those tissues, trying to get rid of the immune complexes. One of our major complications of rheumatic fever is what's called rheumatic heart disease. Now, this is going to happen if they have scarring from rheumatic fever, or if they've had several cases of rheumatic fever. And basically, the scarring has impaired the heart's ability to effectively pump the blood. Rheumatic fever is kind of a self-limiting thing, but serious damage can occur. Our manifestations are going to include arthritis in more than one of the larger joints, carditis, which is inflammation of the heart and its structures. Now, this carditis can be subclinical, so you can't maybe not be able to tell, and it's often only diagnosed by the presence of a murmur. Chorea, which is these involuntary movements, usually of the face, arms, or legs. Erythema marginatum, which is a very bright pink red rash that usually starts around the trunk and moves to the extremities. And in rare cases, these subcutaneous nodules, which are these small, non-tender nodules, usually over the joints. Our diagnosis is made based on the Jones criteria. Now, the Jones criteria is lined out in box 46.1. Your major manifestations are going to be your carditis, polyarthritis, chorea, the erythema marginatum, and subcutaneous nodules. Your minor manifestations are fever, arthralgia, an elevated ESR or CRP, a prolonged PR interval, and what you'll see is that they have a criteria that in order to be diagnosed with rheumatic fever, you must have at least 2 of those major manifestations, or 1 major and 2 minor manifestations. They also have to have the evidence of a group A strep infection. This may be from a history of like a recent scarlet fever diagnosis, a positive throat culture. They may have strep titers drawn, or they may be positive at this time for a rapid strep. So any of those will kind of need to be done to signal rheumatic fever for us. Other diagnostics that we'll use are going to be like a chest X-ray to look for cardiomegaly. We may do an EKG to rule out any dysrhythmias, and we'll do an echo to see how badly the valves are damaged, if they are damaged. Once it's confirmed, the child will be given a 10-day course of antibiotics to treat the strep infection. This is not going to reverse any damage that's done. It's actually just going to stop the bacteria and any further damage. Other anti-inflammatory medications we may be given, such as a steroid or even aspirin, can be prescribed to treat the carditis. Now, aspirin is typically avoided in children. However, in some of our cardiac patients, they will be prescribed an aspirin regimen by their cardiologist. So in this case, aspirin is okay. The child with rheumatic fever is at a heightened risk for recurrent rheumatic fever, and that's we'll typically put them on a prophylactic antibiotic. Now, this is typically we're trying to prevent strep infections from occurring again. Now, the families can choose how they want it to be delivered. It can be a monthly IM injection, or it can be a daily oral pill that they take. Patients, these are going to be more of a long term. So the patients who have had rheumatic fever without carditis will have the prophylactic for about 5 years or until they're 21 years of age, whichever comes last. If carditis is present, the prophylaxis will continue for 10 years or until they reach around 40 years old, whichever is going to be the longest term. Other care that we can include for these patients includes warm compresses on the inflamed joints, placing them in the child in like a position of comfort, maybe even some splinting of those joints, and we may have to use the seizure precautions such as the padded bed rails, bed in lowest position with patients who have severe chorea. This is not an actual seizure, but we still may have to have that available. Parents may also have to take the child's bed and put their mattress on the floor if they are having severe chorea at home. Moving on, Kawasaki's disease. Now, this is also known as mucocutaneous lymph node syndrome, and this is acute febrile inflammatory process. It has generalized vasculitis, but there's not a known cause of it. It is theorized that it's caused by an immune response from viral or even bacterial toxins, but nothing is confirmed. There are 3 phases to Kawasaki's. The acute phase lasts about 10 days. It has high fever that's unresponsive to treatment, bilateral conjunctivitis, changes to the mucous membrane. This is most often going to be a strawberry tongue, swelling of the hands and feet, a very generalized erythematous rash that you see in this picture, enlarged cervical lymph nodes, and an increase in irritability and tachycardia. Now we'll then move on to the subacute phase, and this typically is days 11 to 25. The fever has disappeared. Most of the symptoms are starting to resolve. They're still very irritable. They may have anorexia, so they'll have like a decreased PO intake. And their fingers, palms, and toes will honestly start to peel and have this like peeling that goes on. They may also still have some arthritis, and this is where we'll also get our cardiac manifestations, such as a coronary artery aneurysm. Frequent echoes are actually done to identify these abnormalities as early as possible. Typically what we'll do is we'll do an echo at diagnosis, and then we'll do another echo at 2 weeks after, then 6 to 8 weeks after diagnosis. And then again, somewhere between the 6 to 12 month mark if the doctor wants to. There's also a risk for thrombocytosis during this phase, so that because there increased risk for an emboli or even a myocardial infarction, which is a heart attack. Stage 3 is the convalescent phase. This begins once the symptoms have resolved completely, and this phase lasts until the ESR returns back to normal. Now, in order for diagnosis to be confirmed, the patient must have 4 out of 5 criteria. These criteria are bilateral conjunctivitis, a mucous membrane alteration, again, we most often see this as a strawberry tongue, redness of the hands, feet, a rash on the trunk, cervical lymph node enlargement, and there has to be no evidence of any other disease process that could possibly cause these symptoms. Our treatment includes IV immunoglobulin, which is IVIG, and a very high dose of aspirin. The aspirin is usually between 80 and 100 milligrams per kilogram per day. That's a lot of aspirin for even an adult patient. We're in the children's stage. And this dose is divided into 4 doses a day, and they're given until the fever resolves. Once that fever resolves, we can then drop the dose. It's still pretty high dose. It's 3 to 5 mg per kg per day, and it's given once a day, and this is for up to 8 weeks. Now, if the child has a coronary artery aneurysm, the aspirin regimen will be continued indefinitely, so that 3 to 5 mg per kg will be their lifelong dose. Some things we need to consider is that IVIG actually holds a very high risk for allergic reactions. So we need to take special care to monitor our child's baseline vitals, recheck the vitals every 15 minutes during the first hour of infusion, and then every 30 minutes until the infusion is complete. We're watching for signs of reaction, so itching, flushed skin, tightness in the chest, chills, dizziness, nausea, vomiting, even some hypotension if it is a late. Remember, hypertension is kind of a late sign. If the reaction occurs, we are going to stop the infusion and we're going to administer an IM epi and Benadryl dose. IVIG also can interfere with the body creating immunity from live vaccines, so it is recommended that we avoid live vaccines for about 11 months after the infusion of IVIG. These patients, again, they're going to have this anorexia and decreased PO intake, so we need to monitor and encourage adequate hydration. Popsicles are a really good option. Any child loves a popsicle, but the cold of the popsicle actually helps numb the mucous membranes and can help calm the swelling down slightly. They can be whatever flavor the child wants. We just prefer to avoid like acidic flavors. And we also can do like a Pedialyte popsicle or a Gatorade popsicle, and they can still get some of those electrolytes in as well. Liquids and foods that are higher in calorie but low in acid are also really good options, and so parents should be encouraged to kind of offer their child whatever their favorite bland food is, and this just helps maintain their nutritional intake. Their lips may be very dry and cracked, so they may have to apply like Vaseline or some kind of salve to those lips. They will also have this fever. They'll be very irritable and almost feel like they don't want to be touched. Tepid baths can help decrease and relieve the discomfort from the skin manifestations. Handle the child very gently and try and only do it when necessary. Now, this rash and peeling can also itch, so we may have to notify the provider to see if we can get something like Benadryl prescribed for these patients to stop the itching. Going on to cardiomyopathies. Now, cardiomyopathies, this is known as like damage or disease of the heart muscles. And this happens where the damage is not the result of a congenital defect, no history of coronary artery disease, and there's no other systemic cause to these symptoms and these defects. You have dilated cardiomyopathy, where there is dilation of the ventricles. There is dilation of the ventricles without an increase in the wall thickness. There's hypertrophic, which is hypertrophy of the ventricles and has impaired filling. And there's restrictive, which is this abnormal material that's causing it won't pump appropriately. Your most common is going to be your hypertrophic cardiomyopathy. Again, the cardiac muscles become very enlarged, they become stiff, they're not able to pump the proper way. It is one of the leading causes of sudden cardiac death in our adolescent population. So, if you hear of a child who is out hanging out with friends, maybe they're at practice or a game, and they basically pass out and they drop dead, and they have to start CPR, it's more than likely they had hypertrophic cardiomyopathy and they had sudden cardiac death from it. They can be asymptomatic. That's the thing with these, is they are silent killers. They're asymptomatic until they cause sudden cardiac death. If they do have symptoms, they're extremely, extremely vague. Frequently, they may complain of chest pain or even dyspnea while they're exercising or doing strenuous activity, so it can be brushed off as lack of endurance. They may also complain about palpitations when they're exercising. Again, kind of sometimes it will be brushed off. On exam, these patients can present kind of normally. When we auscultate the heart, it's going to sound relatively normal, or they may have a very small systolic murmur, especially if they've had a recent exertion period. EKGs may actually show some changes if it's severe, and this may lead us to kind of put them on what's called a Holter monitor. And what we're doing is we're screening for dysrhythmias that are asymptomatic. Now, dysrhythmias are an impairment in the conduction and electrical activity of the heart that can cause the pumping ability to be impaired. So we want to track them. Chest x-rays might show cardiac enlargement if it has been going on for a while, but an echocardiogram is the #1 way to diagnose these. It is the diagnostic criteria. Once diagnosed, the child needs to be restricted from all strenuous and all competitive sports. A beta blocker or a calcium channel blocker can be prescribed. We often use these as like a prophylaxis for a ventricular dysrhythmia, so a dysrhythmia that's originating in the ventricles. These are usually more severe dysrhythmias such as ventricular fibrillation or ventricular tachycardia. Surgery can be performed to help release some of that hypertrophy and improve the symptoms, but it still does not decrease the mortality rate of hypertrophic cardiomyopathy. Another option is that the child will have a pacemaker or even an internal defibrillator placed. Now, the pacemaker helps keep them on a regular rhythm, and an internal defibrillator won't what we call kick them until they have gone into one of these rhythms that would require them, or a dysrhythmia that require a defibrillation. So the pacemaker prevents them, a defibrillator treats them. The caregivers also really should be taught CPR whenever they're for this child, because you never know what could happen, and we want them to be prepared for any situation. Now, let's move on to primary hypertension. Now, primary hypertension is also kind of known as like essential hypertension, and this is high blood pressure that exceeds about the systolic or diastolic exceeds about the 95th percentile for that child, and primary means that it's not related to any other disease process. In pediatrics, we typically will see hypertension related to renal impairment, but there is no other disease process involved in this period. The reason we're seeing these is because we're having an increase in children's weight across the board. They have a decrease in activity levels. They're having a decrease in nutritional foods. They're eating more fast food things all along. There's not really a lot we can do once these patients are diagnosed. We will give them, treat them with lifestyle changes. We want them to reduce their weight, increase their activity, dietary modifications, so avoiding high-fat diets, high-fatty foods, avoiding high-salt foods, because sometimes the hypertension can be caused by stress. We want them to use like relaxation techniques and ways to cope with their stress. And then we may have to do pharmacologic treatments. So these are typically something like a diuretic, beta blockers, or some sort of vasodilators to try and treat these patients for the hypertension. We don't want to get to that point, because once you put a patient on high blood pressure medication, it can be kind of difficult to wean them down. So we put a child on high blood pressure meds. We will do it if we have to, but it's hard to try and get them to alter their lifestyle when they just have a pill to fix it. And then we have high cholesterol during childhood and adolescence. Same thing with high blood pressure. You are having these kids, they are not exercising, they're not active as they used to be. They're more sedentary because of, games. They're not involved in sports, or they're eating a lot of unhealthy foods, and so their cholesterol level is also going up. Used to, we only screened those who were at the highest risk, so they had some sort of previous risk factors, such as a family history, if they were obese, if they had type 2 diabetes, if they had a hypertension history, or if they had admitted to alcohol or tobacco use. Now we prefer to screen as many children as we can. So typically between the ages of 9 and 11, they'll have their first lipid profile done. And then sometime between the ages of 17 and 21, they'll have a second one. And this is helping us identify them early, even if they don't fall into any of these risk categories, because you can silently have high cholesterol and not know it. We do want to teach, of course, preventative, so we want to teach them avoid tobacco use, avoid smoking. If they have cholesterol, we want them to try and get their good cholesterol up, treat their hypertension or prevent it if you can, increase their physical activity, weight reduction regimens. So we want them to treat, again, lose some weight, get out of that high risk obesity category. We can't alter any family history, but knowing their family history can definitely help us screen them more effectively. Children who have type 2 diabetes are more at risk for having high blood pressure and high cholesterol as well.